something like that. My interest. They thought it doesn't what I didn't care. So you want to die? I have nothing to do with it, nothing at all.
Okay, sir, we're live. You can start.
Good evening, everyone. A warm welcome from West Bengal Arthroplasty Society. Carrying on after a very bruising last 2 months, we have to get back on our feet. So we started off with a slight webinar with a slight difference. So this is going to be a webinar on knee arthroplasty, a good game plan wins matches. And the difference is not only about cases and orthopedics. We have people here. Dr. Indrani Dotto is going to tell us how to battle stress. And at the end, Dr. B.D. Dr. Indra Shodhar is going to tell us about their other passions that they have been able to use to beat the COVID blues. So without much ado, I think I'll hand over to Dr. Kanchan Bhattacharya to give a welcome address from WBOA. Kanchan there.
Good evening, everybody. So the West Bengal Arthroplasty Society is organizing this. This talk is the second of the 25, right? And I think this always brings in a lot of enthusiasm for everybody. So we have a mixed bag of presentations today, like Rajiv just mentioned. We'll wait for the Arthroplasty Society meeting Vikas to join in and put in his welcome address later. So I think we can start the evening with Rajiv carrying on with beginning with what, Chanda?
Chandanda is going to talk about a difficult primary replacement, knee replacement, how to dodge the bouncers and hit the sixes. And these are Dr. Ronen Rai and Dr. C.S. Dhar. And if I everybody to be on mute in the chat box, and Dr. Ronen Rai and Dr. C.S. Dhar are going to be throwing the bouncers at him. Chandanda, opening basket.
Let me share my screen and thank you, Rajiv. Audible?
একটু জোরে হলে ভালো হয়
আর একটু জোরে it is okay
হ্যাঁ
okay thank you Rajiv and let me share my screen and
screen share, yes.
Rajiv, do you want us to interject Chandan while he's speaking, or does he continue his whole talk?
Present the slides and then we'll ask questions. I think that should be okay.
I have 1 or 2 cases. Let me share. Is this visible? Visible? Yes. Okay. Now, thank you. Good evening. And this is possibly the second webinar of WBOA. And once we had a talk with Rajiv and Vikas that we are too much bombarded with academic scenario nowadays. So why not to get diversion to some extent away from the academics, keeping academics intact, and let us divert into or mix with some non-academic interesting subjects so that in this pandemic boring times, we can have a better time. So Rajiv told me that I'll be talking on the primary knee replacement. I was very happy that we had so many talks on that, so it will be a ready-made subject. But he added a sort of addition to it, how to dodge the bouncer. That part is okay, but how to hit sixers. I'm quite nervous about it, whether I can hit sixers or not. So I'll present you 2 cases, rather 3 cases, case number 1, case number 2, and case number 3. First 2 cases are almost equal. Complex cases, complex primary, I want to highlight on post-HTO TKR. And case 3, you can see this is a complicated primary disorganized varus knee. So how to go about it? Now, at this juncture, we can start our discussion without going into very far. And let me tell that in these two cases on the top, it was conventional Coventry sort of osteotomy. And on the left case one, it was very poorly done. It was extremely poorly done. And on the right side, it was to some extent better. And this is a very difficult scenario. It looks odd and it has to be tackled properly. Otherwise, it might go into a difficult, complicated situation. So let's start discussion in this aspect. And I feel very comfortable that if we can finish on time, and our comment should be very precise, crisp, and just, absolutely just comments. So, in Chandrola, should I ask you or let the ball rolling?
Let the ball rolling fast. And
so, if you get either of these two cases, case one, case two, both are similar situations, post stage 2. And both of them were fixed with staples, and ultimately they were removed. Now, how to go about it?
I think first of all, you should tell how to plan.
Yes, that's why I am asking.
That is, the planning is important. You can say what should be in the material before you start, or how to go about it.
Yes, that's why I want to gather opinion, and then let's start. Ronenda is here also.
Yes, I've managed to join back.
Okay.
You started off with a bouncer.
It's a bouncer, sort of bouncer.
Bouncer, of course, it is a bouncer.
Well, look, basically, if you look at it, you presented 3 extremely complex problems. And as Chandroda just mentioned, that planning in these types of knees will make sure that you don't fall into a trap. Now, basically, what we have to realize is that we should try and remember that to get a successful knee replacement in conditions like this, we should have a knee that is stable. And at the same time, we have to make sure that we keep the constraint to as minimum as possible. So, because, I mean, the easiest option would be to say that, oh, I do a hinge replacement in all these cases and get away with it. But that is not the answer. The thing is that if you can actually aim for a primary implant, that's ideal. Maybe even someone like Vikas would probably say that I try and do a cruciate retaining if possible in a couple of these cases, if at all. So obviously, that's not my choice. The second thing is that if you look in terms of constraint, you'd be looking at first retaining, then cruciate sacrificing, then something like a TC3, or beyond that, if you're looking at, then you're looking at obviously a rotating hinge and finally a hinge. Now, basically what you've got to try and see is whether you can get your gaps balanced or not. And the second thing that you need to realize is whether it's going to be possible to maintain the integrity of the collateral ligaments. These are the main factors that you would actually consider.
Sometimes, Ronin, sometimes in these cases, you see these X-rays and you get so much frightened. Particularly, I'm not talking about the third cases. That is different from the first 2 cases, I think. In these first 2 cases, obviously, once you open it up, the main important thing before you cut the bones and everything, you have to assess the ligaments, collateral ligaments, particularly. See the laxity on what side on what, and start with the minimum cut, I think. And
hey, Indroda.
Yeah, I wanted to comment on this because I wanted to know, number one, is this X-ray sufficient? I think a long X-ray is essential on this case to find out what is the reason and if there's anything up or down below. The second thing, what is the movement range of this? And that will also generate what is to be done. And thirdly is the use of a CT or an MRI on this, because we really know then what is happening to the articular surface, which one has gone, how much it's gone, whether there's a fracture in between or not, which may not be apparent on these X-rays.
Absolutely. In addition to that, I'd go to the extent of saying that we also need to have an examination under an anesthetic if possible, or even preoperatively, to see how much of a deformity is there, how much of a laxity is there, so that you have an idea of where you're starting from. Because just single, whether these are supine films, weight-bearing films, single leg weight-bearing films or not, we really don't know. So these will all give us an idea of the stability of the joint. And as Indraja says, that it's important that we have as much information as possible to enable us to plan appropriately.
One thing I can say that I have not posted these are all weight-bearing films, and long leg film only in case of third you can visualize to some extent, but I have not posted, but these are okay. Hip ankle, these are okay. There is no joint involvement above and below, and the axis is exactly what you see in the X-ray. Now, my point is that when we see that patient, instead of jumping directly towards joint, or it's a decided plan that definitely we are going for the total joint replacement, total knee replacement. Now, what's before that?
What I'm saying, the plan is important before you start the things, whatever. Obviously, examination, clinical examination, I mean, the laxity, how much is correct.
So one point is certain that we need to have a long leg film, standing view, and we have to examine the joint under some sort of anesthesia, maybe short anesthesia, GA, or before operation. Okay, agreed. And anything special?
Well, if you look at it, one thing that's very interesting is that these three different cases, Chandan, is if you look at the tibia in isolation, you can see in the first case, which is a post-HTO, the tibial slope is actually reversed. It's posterior to anterior, right? That's the first thing that hits you. If you look at the second case, you find that on the lateral view, the posterior slope looks reasonably okay.
Yes.
If you look at the AP view, it's in severe valgus, right? Now, if you look at the last one, case number 3, right at the bottom, the slope is completely exaggerated. So you got a severe posterior slope on the third case. So these themselves will give you an idea that where you're going to end up with. So if you end trying for a neutral rotation, even on the first case, you'll end up with a significant flexion gap, right? Because if you try and restore, say, 3 degrees of slope or whatever, then you will find that you will end up cutting more posterior bone and you will have more laxity in flexion. On the second case, for example, on the tibial side, if you try and match your medial side to the lateral side and make a cut, there's a significant chance that you might end up with damage to the MCL. So you might have to do a very conservative cut and try and build up on the lateral side if necessary. Similarly, on the last one, if you look at it, you find that there's no way that you're going to get a posterior slope built into the implant, because the way it is at the moment, you probably got about a 10 or 15 degree posterior slope, or possibly even more if you don't make any cuts at all. So I think in the last case, you're probably looking at a hinge, definitely. The other two, I'd sort of decide on table what we can do. If there's a possibility of a build-up on the lateral side in the second case, I think I'd try and preserve bone and try and go in for less constrained implant. For the first case, I definitely would try and use a primary implant without any sort of, what should I say, additional constraint. In my case, the usual thing is a cruciate sacrificing because I don't do cruciate retaining implants.
Should we move ahead?
Pardon?
Should we move?
Yeah, go ahead.
So problems expected. Previous operative scar, it's a very vital thing for making incision. So definitely before jumping to any surgery, we have to decide the incision. So previous operative scar in a badly done high tibial osteotomy, I think this is a big issue. Second, patellar issue. That's why I was asking so much, because in close wedge osteotomies, a wedge is removed. So the patella comes down, patellar ligament, patellar tendon is shortened. It becomes a patella baha because of quadriceps contracture or a patellar tendon shortening, effective shortening.
What is the problem of patella baha, Chandan?
No, it's a question of eversion of patella. It's a question of eversion. Now, there lies the question then, how do you go for it? Because once operated by a bad or poorly done, I'd show you the scar mark that I operated. Then why I'm telling this. So if it is a patella baha with infrapatellar tendon scarring, then patellar eversion is a big issue. Then just one liner, how to go about it. If you have a very tight sort of patella because of difficulty in eversion, what is the easiest way you adopt? Ranendra, Chandra?
So why you have to do the total eversion? You can slide it on the side.
Okay.
The incision may have to be a little bit bigger in this case. And is there really any shortening of the patellar tendon? Clinically, you haven't seen it. So is it pre-operative findings that patellar tendon is shortened? What do you say?
Well, I mean, I would keep my options open, really. I mean,
Yeah, you have to keep it option open, and on the table you have to see.
look, if it's just slightly tight and if you think you're going to get away with a quadriceps snip, then we can probably try if you're finding
That may require, but you don't know. That's what a clinical exam.
I wouldn't routinely plan my exposure with expecting to do an osteotomy. I really wouldn't.
Patella baha is not because in these cases because of the contracture of
It's a shortened.
No, what is happening actually is in a closed wedge osteotomy, we are actually shifting the tibial tuberosity laterally and superiorly. By doing that, by default, we are creating a patella which is the angle is increasing, and in the coronal view, the patella is coming down basically. So that is the reason for patella baha. It's not the length of the tendon which is changing. What is changing is the alignment of the insertion of the tendon in comparison to the joint line. And therefore, when you are correcting the joint line, we have to understand how much extra valgus we have given at the time of primary HTO, and in order to bring that valgus alignment from say 15 degrees to 4 degrees, that is the correction. And therefore, tibial tuberosity osteotomy is a better procedure to do in a post HTO if your quadriceps snip is not working. In most of the cases, quadriceps snips will work if it is less than 15 degree of valgus. But if it is more than 15 degree of valgus, which is there and it is a fixed valgus, it is not a flexible valgus. In that case, we may have to do a osteotomy of the tibial tuberosity to realign it.
Okay, next point. And we have to take consideration of the malunion of tibia and previous implant. See, this previous implant is in case of nowadays the common practice is medial tibial open wedge osteotomy. So what do you do? you remove the, if there is implant, remove implant at the same sitting, or previously in a previous sitting, remove the implant and in next stage, maybe after 6 weeks, go for care. Chandra, would you do in the first sitting both?
No, it depends. If the other, I mean, the hematologically or otherwise, if there is no signs of any infection or any other inflammation, then you can go with the same sitting.
So suspicion of bad scarring and infection, that will decide whether we'll go for the first sitting or
Stage.
stage. Okay. Taken. So these are the Rajiv's bouncers we are going to tackle. And this is the case. This is another case why I was putting this. This is another post-H2O medial open-edge osteotomy. And this is the plate you can see, and it was done in the same sitting. Removal of plate because there was no scar, and scar mark was absolutely fine, and no sign of external infection, CRP, ESR, everything was normal. So we planned for the primary first stage TKR.
But Chandra, would you recommend that as a routine procedure?
No, not a routine procedure, but here comes your judgment. See, if initially it looks like that everything is in the same, there's no history of any discharge, there is no history of any sort of inflammation before recurrent swelling or inflammation, and CRP and other parameters are okay. Even after all preparations of primary TKR on the table, if I find that any soft tissue is not very much acceptable to some extent, even 1% hesitancy is there, I'll stop. But there are two groups and which may not or will never converge, that what to do. So in that case, I had sort of least suspicion and I went for a primary TKR. So this is the case on the left, first case. This is the scar, and it was very badly done. I'd say, sorry to say, it was almost adherent scar, and it was very badly performed, executed primary HTO. And you can see the knee movement. Maximum under anesthesia, it was 70 degree, maximum. 70. Under anesthesia, it was not done.
That's why it doesn't. Anyway, yes.
It looks like 45 degree, but under anesthesia, it went maybe to some extent.
So, what is the age? I mean, how old is this scar?
How old age is
Scar.
scar? The operation.
Scar. What is the time? I mean, of
It's osteotomy was done 18 months back, 1.5 years back.
1.5 years. It's not that long.
Not long, 1.5 years back.
Yeah.
Hello, good evening, everybody. Sorry, I joined late. Hello.
Hi, BD.
Hello. Sorry, I joined late. I had a problem getting a computer, but anyway, nice to see all of you. Can I ask a question?
Whom it may concern.
Yeah. So, I mean, that scar is very unusual for a open wedge osteotomy. It is, a transverse scar. And yeah, so I really don't know that. I mean, this is not the typical incision which is described by Stauble for the Schwarzman type of open wedge osteotomy. It's usually on the medial side.
That's why the case is here for discussion.
The surgery was not done by Stauble. Somebody better than him did it.
So that's something very strange. It's an adherent scar. So I think you will be So,
No, this was a closed wedge osteotomy.
Was it? But it shows a tomofix plate.
No, this was the other one.
That is different. This is different.
That
Okay. So this is okay. Okay, so this is a Coventry type. They had a staple inside, is it?
Yes, it was.
Okay, all right.
It was.
Chandana, 5 minutes.
Okay. And so as usual, as it was planned, that in every improperly done HTO, I would say improperly done. If I go back, just one or two, you see the femur is femur is typically as that of varus, but tibia is absolutely like a valgus knee. So it's a combination of femoral varus and tibial valgus that we are encountering. So we have to be very particular while dealing with medial soft tissues. So minimum soft.
First case in the X-ray.
It is in the. I'm discussing for the HTO mainly because time is short. So for the HTO, you see the femur is in varus. Femur is, normally is like a varus knee, and tibia we have turned tibia into a valgus knee tibia. So we have to be very particular while dealing with medial soft tissues. So minimum tibial cut like a valgus knee. So we have done how much? 6 mm tibial cut. And in this case, we have used Smith and Nephew, this portable ortho-align device for better alignment. And ultimately, we could get a fantastic alignment. You can see it's absolutely fine, straight.
You could do a CR knee also, I can see.
That's what I said in the beginning.
So first and second case, I would go for CR.
Okay, and so ultimately, this was the pre-op X-ray, and let us see. This is the post-op X-ray in all 3 cases. Any comment?
Yes. All 3 cases.
Wonderfully done, actually.
One question: would you routinely stem them as a routine if you have?
Second case. Why not? I mean, is there any reason? Is it stable with this? Without
absolutely stable. I think minimum bone cut. Most of the as you grow older, now the use of constants are coming down. See, it's basically a soft tissue balancing, minimum medial release, and maximum balancing of himself. So it is absolutely stable knee. There's no doubt about it. Because
I think what
osteotomy united?
Yes, sir.
It's solidly united.
What I hear Chandanda saying is, as you stay younger, you need to be constrained more, and as you grow older, you don't need any constraints because you constrained naturally.
Absolutely.
No, I think regarding the use of stem, if you have a significant step on the lateral side and you need to offset your tibial tray, that's the time you need a stem.
Yes.
That's the time you need a stem, and it has to be an offset stem to hold the diaphysis. That's the first thing. The second thing, there are 2 problems with a closed wedge osteotomy. One is that there is usually a reversal of the tibial slope, and the second, which you need to address. And the second problem is that there is a laxity of the LCL because the fibula rides proximally when you close the wedge. So there is a laxity on the lateral side. So, Chandan, did you have a problem with the lateral LCL laxity?
No. I didn't have any laxity on the lateral side. I expected it. And initially, I started with a lesser tibial cut. And the one I showed, it was 6 mm. Initially, I used to do a 4 mm even to balance the gap. But we have got some of the series, and just in the conclusion, I'll tell that we have missed one thing that I expected all of us to comment on that. So before jumping to any subject, that we have to counsel the patient, because all post HTO care, how best you have done at the end, patients are to some extent unhappy almost always, because they always feel that they are going back, they are going their original knee back. So counseling of post care, post HTO knee, it is one of the most important factors.
Chandan,
yes.
the scar, that patient with that scar, bad scar.
Yes.
Is there any problem post?
No. It was, I expected that, but it was absolutely union in the primary intention. There was no scar. It was an absolute dead vertical incision, right angle to the scar and up to the bone. And almost I took a sliver of bone almost with it. So there's no problem, no vascular problem. So Rajiv is getting impatient. So let us conclude. So what is take-home GAN? Patella baha with infrapatellar fibrosis. It's a concern in case of post-HTO TKR. Femur is typically of a varus knee, but tibia we have converted to a valgus knee, so no medial release like varus knee. And collateral balancing is a critical problem. And never to forget that prior to surgery, patient's counseling is of prime importance. That patient will be unhappy even after you have given your best. So that is one of the most important. So coming back to our original topic, primary knee replacement, how to dodge the bouncers and hit sixers. And we have tried to dodge the bouncers at our best.
Arvind was asking, I think you have put a stem on the third case.
Yes, that was, there was a stress fracture.
Arvind was asking why you did not put stem in the third case.
There's a stress fracture. There was a stress fracture. If you see the X-ray, there was a stress fracture on the proximal third. So we grafted it with the cut surface and just 1 second, grafted with cut surface and used a stem. So the discussion was on primary knee replacement, how to dodge the bouncers. We tried to dodge it at our best and hit sixers. So there lies my restriction. So I delete that or remove that. My take on this is how to remain unhurt of those bouncers or keep your wicket intact. Thank you.
Thank you, Jandanda. Wonderful cases and wonderfully presented. And thank you everybody for joining in. Can you unshare the screen, please?
Yes.
I would like to invite, so we go from orthopedics to non-orthopedics, and we have all been stressed over the last few months. So can I invite Dr. Indrani Dotto? She's a clinical psychologist. She's done an MPhil from Central Institute of Psychiatry, Ranchi, PhD from Calcutta University, practicing in Kolkata. We were together in West Bank, erstwhile West Bank, and now she's with Narayana Multi-Speciality and Super Specialty Hospital, Crystal Mines, and Monon. And her main area where she works is positive mental health, mainly stress, anxiety-related disorders, and OCD. Over to Dr. Dotto. Can you share your screen, please?
Yeah. Good evening, everybody. Thank you, Dr. Chatterjee, for giving me this opportunity to talk in this platform. I am misfit in this platform because all of you are in the Department of Orthopedics and I'm out of it. But can I share my screen?
Yeah, please go ahead, share the screen.
Can you see?
Yep.
Yeah. Today, my topic is stress management. Last 1.5 years almost, we all are going through a very peculiar phase of our life. And I think everybody, starting from child to the geriatric person, everybody is stressed out for something or the other. So it's a very relevant topic for present time. So what are the major psychological impact of pandemic? Due to pandemic, we have a severe sense of loss of safety and predictability, control, freedom, sense of security, and basic psychological issues which all are facing, worries, anxiety, fear of having illness, death, etc., fear of losing job, losing loved ones, fear of isolation, fear of scarce resources, feeling low, change in daily routine, change in sleep cycle, appetite, etc., and spiral negative thought. All these resulted in displaced anger, irritation, interpersonal conflicts, and poor frustration tolerance. Now, as we are talking in the platform where many of you, all of you rather, are surgeons, so there are certain lifestyles you all are probably will agree with me that hard work, long working hours, dealing with critical situation in daily life, huge volume of work, meeting multiple deadlines, sacrificing personal life are usual pattern of surgeons' daily schedule. Now, there is a fine line between hard work and overwork. Overwork may be counterproductive in the long run. And working as a frontiers, providing health services to many and ensuring physical and mental health of the family as a whole are also a huge burden on the doctors. Huge cutoff in the number of surgeries and disruptive routine are also a major concern. Apart from anxiety and depression, we will talk about burnout, which is another outcome of severe stress. Now, stress is many a times it is simultaneously synonymously used with anxiety, but anxiety and stress is not the same thing. Stress is the body's reaction to the threat, which is typically triggered by external factors, and anxiety is body's reaction to the stress, which is also persistent even after the stressor is not present. Now, anxiety has a different model of explanation, but we are here, we will discuss on cognitive model of anxiety. Cognitive model of anxiety explains anxiety as people's expectation and interpretation of the events, which leads to negative emotions. Beck has defined it as overestimation of danger inherent in a stressful situation automatically activates the anxiety program. A set of responses get activated when we are in a stressful situation, changes in autonomic arousal, inhibition of ongoing behavior, and selective scanning of environment for possible sources of danger. We selectively scan only the negative aspect and ignoring the positive aspect of the situation. Now coming to the coping part. Coping is a set of behavioral and cognitive efforts which is being used to manage the demands of the stressful situation. And coping style of a particular person will be determined by the individual's learned response in previous stressful situation and how the person is analyzing and attributing to the situation. These are all the determining factor. Different forms of coping mechanisms are available, mostly problem-based coping mechanism and emotion-based coping mechanism people use. Those who use problem-based coping mechanism, they are aimed at resolving the stressful situation or the event and altering the source of stress. Whereas emotion-focused coping mechanism are aimed at managing the emotion associated with the situation rather than addressing the situation itself. Now, we human beings, we always try to be in control. We always try to control the outcome of the situation. And whenever there is any distraction from this sense of control, then we feel very unsafe and insecure. So feeling in control is a way of coping. Optimism and pessimism is another coping mechanism, another coping style rather. So optimistic, those who are optimistic in nature, they find some way or the other to work on the situation, stressful situation, and they find a way out. But those who are pessimistic by nature, they easily give up and they don't find any way out in a particular stressful situation. And there are other coping styles also. I'm not going into detail of approach and avoiding coping. So there are various personality variables that are related to the successful coping. That is dispositional optimism, as I discussed just now, conscientiousness that promotes the positive mental health related attitude, and the hardiness that includes a sense of personal commitment, personal control, and positive responses to challenge. Now, appraisal is a key component of coping. How people appraise or think about a potentially stressful situation, that determines how they will feel about the situation. That's why stressful for one person may not be stressful for another person because the appraisal differs. Primary appraisals are those, a set of cognitions that regarding the importance of stressful situation. A typical stressful situation may not be considered as important to a particular individual. So they will not feel the same stressed as the other person who is thinking the situation is very significant in their life. And the secondary set of appraisals are the cognitions concerning individuals' resources for dealing effectively with the situation. Sometimes we try to teach the patients or our clients that you need to reappraise your appraisal. You need to reframe your appraisal or reappraise in order to cope better, in order to cope adequately with the situation. Because if you think that the situation is a challenge for you and it's an opportunity rather than a threat, you'll definitely cope better. Now, in short, this is the thing we just discussed right now. In environmental stimuli, then we perceive what we'll select. We select the stimulus which we'll react to, and then primary appraisal, interpretation of stressors. If it is positive, then adaptive way of coping. If it is irrelevant, then we just discard the thought immediately. And if it is perceived as dangerous or challenge or threat, then we become very anxious. And then there comes secondary appraisal, which is the analysis of available resources of the individual. If the person thinks that he or she has sufficient resources to deal with the situation, then he feels very secure and safe. But if the person feels that he or she has insufficient resources, then the stress occurs. And now coming to the coping, which I have already discussed, the problem focused and emotion focused. Now, the concept of burnout is characterized by emotional and physical exhaustion, poor judgment, feeling of ineffectiveness, and a decreased sense of personal accomplishment. In a high stress moment, we have all these symptoms, this headache, muscle pain, and we are all aware of there are a lot of difficulty. People complain about breathing, sleep pattern, loss of appetite, unable to focus, easily get angry, etc. Whenever we are in a stressful situation, we get hooked by negative thoughts, spiral negative thoughts and feelings, and we get unfocused as a result. So immediately we need to unhook ourselves by refocusing or engaging in what we're doing. And that is called mindfulness. We'll come later to this concept. Now, if you divide the whole situation, whatever is the situation, in two different halves, like things under your control and things beyond your control. We can only work on things under my control, under our control. So that will again help you to engage in what is necessary and what is attainable. Emotional storm is used to describe a situation where there's intense, difficult thoughts and feelings, and which has an overwhelming effect on the individual. We immediately need to ground ourselves when our emotional storms appear. So it is better to engage in life, pay attention to others, focus on what we are doing, and live life by our values. We'll manage stress in a better way. Values describes the sort of person you want to be, how you want to treat yourself, others, and the world around you. And goals are what you are trying to get. So now during this pandemic situation, many of your goals might not be possible right now to attain, but you can always find your ways out to act on your values. You can question whenever you're puzzled, confused, or emotionally in an overwhelmed condition. You can question yourself to ground yourself that are your actions moving you towards or away from your values. In this way, we can again ground ourselves. Now, there are certain steps to promote our personal well-being. That first of all, identify, reflect, and balance between personal and professional priorities. Focus on most promising and personally meaningful areas of your work. Periodically reassess what you can enjoy most of your work. And identify and nurture the personal wellness strategies, which we all professionals are usually overlook. Protect and nurture your relationships. Develop hobbies and use vacations to pursue non-medical interest. Ensure adequate sleep, exercise, nutrition, etc. And define and protect time for personal reflection at least once in a month. So these are the various methods how you can manage your stress. Just have a look on it. Now coming to the concept of mindfulness. Mindfulness, the history of mindfulness is long stretched and almost 2,500 years in the Buddhist tradition, where mindfulness and compassion is seen as a path of genuine happiness and enlightenment. The concept of mindfulness is used nowadays, at least in combination with cognitive behavior therapy and many other therapeutic strategies. The practice of mindfulness dramatically reduces stress and replaces the negative reaction with a vibrant awareness of joy and enthusiasm. Mindfulness is seen to be linked with better quality of life, reduced emotional exhaustion, optimum emotional reactivity to stresses, It improves executive functioning, better attention, reduced emotional interference, decision making, and better behavioral regulation. Finally, mindfulness also linked with sustained improvement and recovery of immune function. The minding your minds during pandemic. Whenever we are overwhelmed with emotions, what we can do? First of all, sit quietly, breathe slowly for a few minutes, distance yourself from the anxious thought, and think about something which is calming and serene. Slow down your mind for a time being so that you can think with clarity. And second thing, when you are feeling angry and irritated, you can calm your mind by counting back from 10 to 1, or you can distract yourself in any other way, whichever is suitable for you. Ask yourself what is under your control. Am I unnecessarily worrying about the situation? Am I thinking that only the worst thing that can happen? How I have managed in the past? What are the things I can do to help myself? And feeling lonely outside is quite common. Stay connected with others so that you can lessen your feeling of loneliness. Coping attitude actually focuses on the available resources. Focus on learning new skills, engage in more family time, reframing the thought are the few techniques which you can use during your stress moments. That during this pandemic, we can think about this situation not as a threat, but as a opportunity to think or focus on yourselves and reorganize yourselves and take care of many unfulfilled wishes. Focus on long-awaited and avoided project or task and do some productive work. Feel free to connect your fellow mental health professional whenever the anxiety becomes overwhelming. Setting up mental zones for each activity, loosening the boundaries, just muddles up your routine. So if you fix up certain mental zones for each activity, that will make you happier. And use some relaxation techniques, meditation, imagery, muscle relaxation can all help to reduce stress. Apart from anxiety and stress, we can talk about grief, which we all are facing. And during the second wave of pandemic, we have all lost our colleagues, juniors, and near and dear ones. So grief needs some attention. It has its own course. We cannot make it faster. We cannot resolve it faster. It has its own course of action. So it needs recognition that I am experiencing loss, and give time to yourself to adapt yourself to the loss. Pay attention to your feelings and think about your strength and coping skills. Stay connected. Create an adaptive routine to ensure the sense of order and purpose. And focus on the things that you can control that will lessen your grief and make you happier. Now, if I have 3-4 minutes more time, then I can go through some relaxation exercise if you are interested in. If you're interested in doing it right now, I can take only 3-4 minutes and do it. Dr. Chatterjee?
Shall we just take questions if from the any questions? Any help needed?
Yeah.
Any questions from anybody?
Yeah, BD here. Can I ask a question?
Yeah.
Yeah. Thank you, ma'am. I think it was a wonderful lecture, and we are really privileged to hear this. In fact, what I shall be talking will be actually almost an epilogue of what you have very beautifully set out. So my question is, you talked about working hard and overwork. So how do you differentiate the two? How do you know that you're working hard but you're all right, or are you getting overworked and you have to do something about it?
Yeah, it's a very good question. That's why I told you there's a fine line between hard work and overwork. See, overwork means there has to be some priorities in your personal life as well, and there has to be some certain priorities in your professional life. So this professional and personal life has to be balanced properly, so that you're not snatching time from other activities, and you're not taking care of your own personal health, and you're not taking care of any other wellness strategies, and only working for your profession. So that definitely creates a lot of extra tension because you're not nurturing other abilities of yours.
Okay. Any further questions?
I have one question.
Yeah.
The question is simple. You see, most of us are in the age group where our children are not with us. And one of the greatest problems of this is that we worry, especially in these times. there is no clear-cut way we can deal with it, and we sort of forget it and then tell them this, that we have, contact them with phone calls, this and that. But at the background, it is always there. There is there, I don't think there's any other way to do to avoid that. But do you have any specific things?
Can you just reframe the question once again? I couldn't hear.
Most of our children are away from us.
Yeah, yeah.
And in these times, we tend to worry a bit. It's mainly in the background. It's mainly in the background over there. And we know we have to worry. There's not much we can do about it. But leave them to their whatever situation they are in. But is there any specific ways you can recommend in which we can
definitely
communicate with them or tell them from afar as to what things which will lessen our stress and their stress?
Right. See, there are certain things I talked about in beyond control and within control. Again, here we can discuss that there are certain things I can control. Sometimes parents try to control or ensure the safety and security of the child and safety and security of even they are growing old. They want to ensure that they are all right everywhere, wherever they are all right. So that creates a lot of anxiety. Parents have to reframe their thought that I can, after the children have grown up, they are not following each and every details or each and every word of the parents. So if you can control those issues of worrying, that which is not under your control, you can stay connected, you can take money, just give some advices on your part, but let them conceptualize on their own part and let them listen to that according to their own process. Because you cannot expect that whatever we will say, they will follow. They will follow whatever they will perceive. So let them do whatever they want. But on our part, I can just suggest as a parent, as an elder, I can just suggest do this and do that, and it will be better for you and it will be beneficial for you. But after all, we have to live up to them.
Can I chip in for a minute? I am Dr. Kapoor. The practice of selective detachment is something which is in ancient Vedas, and it is a principle which has been studied in the texts which are of our great literature. So the principle of selective detachment is something which we need to practice in daily life, not only with our children, but with our colleagues, with our students, with our people whom we work with. So, and the institutions. So it keeps you mentally in a space where you are somewhere in the midway zone. And I think so, I don't know how you people call it, but I look at it from the point of view of our maybe Vedantic.
Absolutely said it in a very simpler form, but it is understood. What I said, you just reframed it, but it's really the selective detachment what you're using. That we just distance ourselves from something because we cannot control everything. So we have to accept that fact. We cannot control everything. We cannot ensure everything for a child or whoever, our patient. Whenever the patient is coming to you, you can suggest whatever you feel like, but you cannot ensure that they will follow all the suggestions given by you. So like that, whenever you are dealing with your own child also, we can just suggest them what is better, what can be better for them. But sometimes they also give some suggestions to us also. We need to listen to them. Otherwise, they will feel that I'm just imposing my thought onto them. So listening to them is another skill we should develop.
I think Dr. Datta, can you just show us some exercises? 2 minutes?
Yeah, just I'll take 3-4 minutes or maximum 5 minutes. Can you sit comfortably in your chair, wherever you are? You need to open your specs, close your eyes. Sit comfortably wherever you are and try to concentrate on your breathing first. Keep both the arms on your lap, both the legs straight down from your knees, and head in a straight position. Alignment of shoulders has to be proper, in a proper position. No, Dr. Chatterjee, little down, chin little down, chin little down. Okay, okay. So now remove all the stray thoughts from your mind and try to concentrate on the breathing process. Breathe in and breathe out in a very normal way, normal rhythm. Just breathe in Breathe out. Slow down your breathing. Concentrate on the rhythm of your breathing. Now we'll concentrate on each and every part and try to loosen that part and feel relaxed. First of all, concentrate on your arms, both the arms. Make it loose and light. Feel both the arms are becoming loose and light. All the muscles are loose and light. Feel relaxed. Concentrate on the relaxed feeling. Now concentrate on the forehead. Feel that something heavy is going down and you're feeling light, lighter than the feather. Concentrate on your eyelids. Feel the heaviness on your eyelids. Feel relaxed. Concentrate on your jaws and other facial muscles. Make it loose and light. Feel relaxed. Now drop your shoulder ends. Feel that heaviness is going down gradually and you're feeling relaxed. Now concentrate on your chest and abdominal muscles. Make it loose and light. Feel relaxed. Now feel that the upper part of your body has become lighter, lighter than the feather. Now concentrate on the lower part, the thigh muscles, the calf muscles, and make it loose and light. Now feel that the whole body has become lighter. Concentrate on the lighter feeling. It's lighter than the feather. Feel relaxed. Now all of you, can you just chant the word relax while breathing out within yourself? Just say along with your breath out, say relax. Within yourself, relax. 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 Just do it for a few moments. Now we will wind up. Slowly, just rub both the palms against each other. And just wipe your eyelids with the lower end of your palms. Now, open your eyes. How are you feeling?
Better.
So this is the power nap or Vedic nap which we do.
Yeah, you can do it any time of the day, but if you practice it every day, it will help you to do it on spot because you'll be in control always. Whenever you're feeling restless inside or any kind of stress, whatever may be the reason, you just sit back and you can do it. If you practice it every day, then you can do it anywhere, while walking, while driving car, while talking to your patient, or while doing OT, etc., etc. You can do it everywhere. Just drop both the ends of the shoulder. Immediately you feel relaxed wherever you are. And this chanting relax will preoccupy your mind with this particular word, and all the other thoughts will get removed. So that way you can just relax yourself and you can practice it every day.
Thank you.
Thank you, Dr. Datta. That was wonderful. I think all of us have to thank her for sharing this fantastic experience. And
thank you.
I can't thank you enough for this. So from the West Bengal Arthroplasty Society and WBOA, thank you again.
Thank you once.
Wonderful.
Okay.
Thank you.
This relaxation session, we carry on for the next one. Difficult revision knee plan. Plan your placements to avoid leaking runs. Vikas, the field is yours. You can share the screen. And in the meantime, also just to pass on the message that CureWell has been kind enough to sponsor the program. So just help them up with Calbona. Please, it would be great. Thank you, Dr. Datta.
Excuse me, Dr. Chatterjee, can I leave?
Yes, thank you. Thanks a ton. Thanks a ton.
Thank you, everybody. Thank you.
Experience for all of us. Thank you.
Oh, thank you.
So can you? Is my screen visible?
Yes.
Yeah.
Okay. So without much ado, I don't know whether runs are leaking or what is happening, but with a revision knee, well, this starts in 2018 when we did a 66-year-old gentleman with bilateral knee, 0 to 90. You can see the deformities, 20 degree, 30 degree. and standard cemented depot CR150 size 4, tibia size 3, insert 10, and on the left and 8 on the right. So that was the normal configuration. This was the knee, reasonably easy knee for all of us, standard varus knee. Well, Englishmen would call it very, very bad virus, but I think all of us, this is what we expect in a routine practice. And I sort of have not used wedge in last 12, 13, 14 years. Since I started my cruciate retaining work, most of my knees have these screw post supports on bad virus posteromedial built up, and has worked very well, has a follow-up of 10 to 12 years now. On both sides, it's a cruciate retaining construct, which we can see here. After 2 years exactly, when this gentleman was 68 and was doing a daily quota of walking of 5 kilometers, was overzealous, fell down, and damaged his left knee, which had an 8 millimeter insert. And this is what happened. The whole knee kind of opened up on that side, and there was a displacement. There was a fracture basically due to fall. So what are the revisions goals? My goals are these. My goals are ease of an adequate implant removal, bone preservation, minimalistic approach, how much we can conserve our approach, minimal constraint, and of course, as Ronenda said, incorrigible PCL preservation, even while doing revision. I don't know, but I thought I might try as well, since Ronenda wants it all the time. Okay, so, and so this was, I don't know, yeah. So this is how we started. You can see the exposure, and it will be a completely a video session, which I have planned. This is done two years back, before the pandemic started in February 2020. This surgery is done. So this is a standard exposure, and standard surgeries which we do are without tourniquet for all the time. So revision also we do without tourniquets, and we expected some scarring. So liberal use of cautery and etc. is done to make sure that we get a quick and fast exposure, and at the same time we control the bleeding. As we go medially, we extend the knee and kind of do the exposure on the medial side. So here you can see after the quadriceps exposure, the medial exposure is done to facilitate the flexion of the knee and then carry on. After having done this, this is the photograph. I think, yeah. So here, I'll go on to this video. So after I did the exposure, I realized that I could not do complete subluxation of patella. So I did a small rectus snip, which you can see in the proximal aspect of the knee here. And then the exposure was easy to do. Having done that, you can see the exposure again. This is the quadriceps snip. And we open up the knee. Once we have done this, we go ahead. The patella has subluxated laterally, and we do our extensive medial release so that we are able to get a good exposure on the medial side where there is a fracture and there is a subluxation and the screw breakage, screws sort of has become loose or whatever has happened at that time. At the same time, we do a bit of intrapatellar release and going up to the insertion of patella so that we can take away the scarring. Having done that, the next step is to expose the knee completely. So we have done a quadriceps snip, we have done a good medial release, and I have now exposed the knee reasonably well. Sometimes a little bit of skin exposure on a secondary basis is needed so that we can have a good play of the tissues and we can kind of not compromise on the exposure of these knees. Yeah, so this is, I think we have seen this video. I think it's playing again and again the same thing. Once we've done this, we take out the poly, which is easily removable in CR knees. This is, of course, a CR knee, as you can see that. And after having taken out the poly, we now protect the PCL. So you can see the PCL virtually here. This is the posterior cruciate ligament. And it is, I can palpate the ligament. It is completely intact. It has not been damaged. And this is a well-fixed femoral component also. So what we essentially have is a good balanced knee, which has got fractured because of the fall. And there is a primary compression of the tibial component with the loosening of the tibial tray because of the fall. This is our assessment of the situation. So once we have done that, we see the PCL, etc., and then we try to expose the tibial tray adequately enough so that we can take it out without much ado. Once we have done, as you can see, the tibial tray then starts becoming or subluxating out. There is very thin rim of cement below, and we try to take out the tibial tray. I have done some osteotomy, which I have not shown in this particular case, to loosen the tibial tray. Once we have the loose tibial tray, we take it out, as you can see here. So the important thing is to protect the anticipated femoral implant, which we don't want to damage at this point of time, as I am already planning in my mind to protect the PCL and the femoral implant, and redoing this knee by only changing the tibial component and putting in back a tibial, cruciate retaining insert. So once we take it out, this is what we see in the knee inside. And you can see the screw here, which is quite loose. And sometimes it's very difficult to take out the screw because the screwdriver doesn't work. The screw is stuck. And therefore, this ronger again, which helps me in doing the exposure of the knee, comes very handy. So the ronger takes out the screw and without much of a problem. And once the screw is out, we do see the crater at the back, which is left behind with the screw out. And here you can see the situation of the tibial condyle. There is a large amount of bone, as you can see, which we still have, which we have been able to preserve. And this is the crater, which is a fractured area at the back. But at the same time, there is enough of tibial cortex behind that. So we have a good rim of tibial cortex all around. So we had a bad situation on the X-ray, but things are looking up as we kind of see the intra-op situation in this patient. And this is what we have retrieved. So you can see we hardly have any bone here. It's all cemented. In fact, you can see the impression of the screw also, which is on the cement. So, and of course, it's 2-year-old poly only, so not much of a damage there. So it was not a primary wear or something which has happened. And here, interestingly, you can see the cement inside the mantle of your canal, this canal of the cemented plate also. So now we do a bit of curettage. We try to take out as much cement as possible. Be gentle with everything. We have this crater here. We have this crater here. But we have a large amount of bone. We do the wash. We try to understand and see the situation well. I'm happy that our PCL and femoral component is very, very well intact. So once we've done that and assess the situation, then we start our, I take a gouge and try to take out the bone which is there inside the medullary cavity and the medullary canal. So once you've taken and hit the bone out, you take a small primary reamer, which is like 8 millimeters, and try to cut through the cement which is there, residual cement inside the canal, and try to create an open canal so that we can go ahead and do further reaming. So as we do this reaming, we create different size of reamers. All of us are quite familiar with progressive reaming of the reamer and then getting our 12 millimeter or 12.5 millimeter thickness in reamer inside, so that we can prepare. Now, what I was planning in this case was, since I wanted to put back a small thin insert, I was planning to keep the joint line intact. I was trying to keep the joint line intact, and I had preserved enough bone. So my plan was to give a metaphyseal sleeve which was load bearing on the metaphysis, and therefore we will be bypassing most of the tibial surface, and at the same time retain the joint line. That was the whole game plan during this surgery after we started it. So once we did that, this is what, and this is the reamer now coming in for metaphyseal sleeves. Slowly we start reaming and trying to achieve our final 12.5 millimeter. And then we put in I usually take this angel's wing, and here I am trying to see whether there is a slope or it's a flat surface between the posterior cortex rim and the anterior rim and the anterior surface and the rest of the surface. So I was trying to assess here whether I need to do or create any more slopes so that I can anticipate how much little I have to cut if I have to. These are all visual acumen and measurements which you do while doing this surgery. And this is the reamer for these metaphyseal sleeves. As you can see, there is a varus angulation of the tibial surface, and the lateral surface is slightly more than the medial surface, which is on sloping side. So this is the metaphyseal reaming. Once we have done this, we take again and we see what is happening here. We clean it up, and well, here we put in the trial and we broach the metaphyseal area for preparing this for the implantation. And along at the time when we broach it, we keep the broach at a flush level with the lateral surface of the tibia. And this broach kind of acts as a place where we have an assessment of what is the joint line we want to give. So once we know that this is the joint line we want to give, the extra piece of bone which is there on all the sides, we know how much to shave off in order to get a minimalistic bone shave off. You can see here, this broach is now at same level as the tibial surface on this side, and this broach exposed is showing how much tibia is lost on this side. So technically, almost half or 2/3 of tibia has a reasonable coverage at the back and in the front, and only on the posterior medial corner there is a slope from where the this thing had gone. So here we put in a tibial insert or trial. After putting in the tibial trial, we put in slap it in, and then we do a small trial reduction. So we are ready for the trial reduction. We can see easily that there is a space here, but my issue is not that this space, I don't need to build it up in such cases. The message is that the whole weight is going to go into the metaphysis. So metaphyseal sleeve is a savior in cases where there is a bone loss of less than 1/3 or 1/4 bone loss on the tibial surface. You can manage it because all the weight is going into the metaphysis. You are not really, and if your edges are intact on the sides, you generally kind of get away with some amount of bone loss also. I think this is again the repeat. There's something wrong here. Now you can see what I did. As I said, we did the shaving after understanding how much more bone. So an extra bone on the lateral side was removed just like a sliver. So we don't need to cut much bone here. It's not that revision, you have to put a lot of constraints, you have to cut the PCL, you have to take out the femur. That's not the idea of revision. The idea of revision here is it's a single stage fracture revision, and you need to address the issues which are created by this injury. It's not that you are going gung-ho about the implant happiness, I will distal femur replacement and all kinds of things just because I'm doing a revision. So here we kind of again take our final broach, we do the tibial preparation, And here we see the final preparation being done. And again, we can do a trial after this. So once we come here, we are here ready for the trial. And at the time of trial only, you know how the surgery has gone. This is full extension, a 10 millimeter spacer, cruciate retaining, rotating platform. And you can see here, patella tracking well. At 90 degrees, no laxity at all on both sides. There, I am showing you deliberately the space there between the tibia because I am very confident about the metaphyseal sleeve. So you do this, and my way of testing the mid flexion instability is I start doing flexion extension with the heel intact, with the pressure on the heel, and then do full range of motion flexion extension as I extend. So at any range of flexion extension, I try to assess whether the laxity is changing. And here you can see there is no laxity change while we are doing flexion extension. So therefore, my mid flexion instability is not there. The ligaments, all three are perfectly balanced. My patella is tracking well, and all the goals which you need to do a successful TKR are achieved. And once you've done this, you get back to your standard preparations of cleaning, broaching, and yes, now my favorite test, the PCL swell test, where I test my PCL by putting in 5 ml of antibiotic or normal saline, and my PCL is intact. After I've done that, I give my injections. And all the sites we have injected, I inject my antibiotics, I inject the tranexamic acid. We do all kinds of local anesthetic, etc., whatever the cocktail you call it. Everybody has his own. So once we've done that, now we are there for the final implantation. And this is the final prosthesis. You can see uncemented sleeve, which goes in very beautifully. Everything is on the bone regeneration at the sleeve level, at the metaphyseal level. You need about 2/3 to 3/4 of bone surface and the rim of the tibia to be intact to put in a sleeve like this. And it is really a wonderful piece of apparatus which can actually help you get back your PCL, and you can preserve a lot of bone and do a very, very simple and a straightforward surgery in situations which are quite demanding and complex. So this is the final tray. You can see how nicely it is sitting. So 3/4 of the this thing is supported by the bone, and the rest is at the metaphyseal level at the sleeve. And that is the intent of keeping the metaphyseal sleeve. So once we have done this, we have put in our knee, and you can see again, I am testing the same way. You can see absolutely no laxity. It is a 10 millimeter spacer, a PCL retaining knee, the same femoral implant, only the tibial side has been changed. There is an extender, and this patient was done 1.5 years back, and today still walks. So this was the surgery done. The surgery was a revision TKR, tibial tray, MBT revision size 3, MBT revision metaphyseal size porous, 37 PFC modular fluted rod, 12 mm, tibial insert rotating platform, curved CVD 4 and 10 millimeter platform. So from 8, we have gone to 10 millimeters, which is perfectly acceptable in a cruciate retaining situation. And this is intra-op measurement. This whole thing you can see is where the weight bearing is happening. So load sharing is happening here. It is not happening here. And this is the X-ray after the surgery. And I will share, we have the recent X-rays also. I think I will close here. This is the final, and these are the post-operative photographs. I think we'll just skip this. We have done our job. Thank you very much. I hope not many runs have leaked, Rajiv. Thank you. Thank you so much. Have I been audible? Everybody has been so quiet. I could not understand.
Yes. We were engrossed with it.
Thank you.
One question, Vikas.
Yes,
Why
sir.
not a tourniquet?
I stopped using it long time back. I get fixated to certain things, Indruda. I don't just.
No, what is the advantage in this case? It's a revision.
In this case, it's a revision case. I had enough exposure. I had no bleeding. My usual BP is around 60 to 65, and there you could see it is technically 1 hour 40 minute surgery. The 45-minute surgery total for 50 minutes. So technically, you need a tourniquet only to control bleeding. And when you operate in flexion, you don't need tourniquet. I start in flexion, I end in flexion. There is hardly any time I extend the knee once or twice during the whole surgery. And when I'm not cementing, why do I need a tourniquet? I only need tourniquet for 5 minutes when I need to clean off all the muck during cementing. That's the time I use tourniquet in routine surgeries. So, and the best part is never giving drains. You don't need drains after tourniquet. The pain is less. Definitely, there is a lesser pain score. The mobilization is faster. And of course, there is no need of any fat to worry about embolism, etc., etc. All the tourniquet effects which you have. So once you get used to operating without a tourniquet, it becomes a habit, and that's why. I think I have no other explanation.
Vikas,
yes, sir.
You don't use the tourniquet in all revision cases, or just?
In most of the revision cases, except in infection. In infection, you have a two-stage revision. You have to take out more extensively. So I could have always put on the tourniquet. Tourniquet is always tied to the patient. That is a habit. But that is for a situation where you need to understand that something is going to, the surgery is going to become more and more prolonged, or you need tourniquet for better exposure, etc., etc. That is the time you always have that flexibility. But 99% of the time, it just finishes off and you don't need it. But it's not that I don't tie it. It's always there. It's there.
Another question is,
yes.
This cocktail you put it in, you have any study or anything whether this makes really any difference if you put it or if you don't?
It is not a cocktail. What I actually put is there is first anesthetist. So local anesthetic, definitely there is a study. We have done a thesis in anesthesia, I think 5-7 years back. We have a thesis on tranexamic acid in anesthesia, and our...
No, that is okay, but giving locally, how much does it help really?
I'm talking about locally only. I'm talking about the local effects only. The pain scores, the what do you call? I mean, we can only quote papers and studies and thesis which we have done. And once you start believing in it, you start doing it. It becomes a part of the protocol.
I used to do it, but now I stopped doing it because
there are umpteen number of reasons. But I give antibiotic, therefore I give anesthetic, therefore I give tranexamic. Tranexamic acid and antibiotics have a reason. You can or cannot use local anesthetic. That is your decision.
Local anesthetic I'm talking about.
Yeah. And I give, yeah.
Yeah, I just want to make one comment, because what you have done is a partial revision.
Yeah.
Now, it's interesting that this concept of partial revisions has undergone a paradigm shift in thought. You see, if you look at the papers about 2 or 3 years ago, they were all very critical of partial revision, so much so that there were several authors who have said that there is no such thing as a partial revision. If you have to revise, you have to revise everything. Now, this has undergone a change. And if you look at the articles coming out from 2019 onwards, people are moving towards partial revisions. And the logic way is that, okay, I mean, if you can get away with it, then why not? Because obviously it decreases the operating time, decreases the surgical trauma, decreases the cost and everything. The problem with a partial revision in the knee is when you have a problem in a flexion extension gap mismatch. That is the time when you will have to change the femur as well, even if it is well fixed.
Yes, I agree. But yeah, that is exactly what I did not have during this, as you saw it. So it was a stepwise decision. The first decision for partial revision was that femoral implant was very well fixed and PCL was intact. That was the first reason. During surgery, I had everything in my hand. The second revision reason was when I saw and I proved that I have a 10 millimeter spacer and a perfect balance and a perfect alignment. So when you are cross-checking at every step, it is about cross-checking and not denying yourself the luxury of having those implants with you. So don't take me wrong. I mean, I would have a distal femur replacement.
No.
Yeah. I mean, what you are saying is...
I fully endorse your view that when you can get away with a partial, then why not?
I agree with you entirely, BD. In fact, during the so-called trough of the lockdown, I had this patient who had a extremely well-fixed stemmed tibial component, but had sustained a fracture through a metaphyseal, just proximal through a metaphyseal sleeve, which unfortunately did not have a stem to stabilize it above. So she'd actually fractured and the whole thing was gone. So we managed to actually get away with, thankfully, there was a matching stem available, stemmed implant available to give a hinge with the existing rotating platform. So we managed to put in a rotating hinge without actually disturbing the tibia. The tibia was actually going down almost, halfway down the tibia. So thankfully, I didn't have to take that out. If we had to do that, I really wouldn't have had any tibia left. So I mean, it's one of those things that happen.
The common scenario, what you would face is there will be an increased flexion gap and a reduced extension gap. Then in that situation, you will need to sometimes you will need to distalize your femur or increase the posterior offset.
Yeah.
Then you will need to change the femur.
There is a whole algorithm for that, and I'm sure we have had Dr. Chatterjee, Dr. B.D. Chatterjee. I think you yourself would have spoken on many forums regarding this, how to match the flexion extension gap with this balance. So, point taken, very well taken. Thank you.
Okay.
And Ronan, that case which you were discussing, that case which you did was a terrible case. Congratulations that you did it the way. I don't know whether but I have seen that patient, I think, which you were mentioning.
Yep, I think most of us here have probably seen it at some time or the other.
Yeah, because I remember that patient which you were discussing just now, if I'm not wrong. And it was a terrible fracture and a rheumatoid patient, if I'm not wrong, very fat.
No, not rheumatoid.
Okay, there must be something else.
Not rheumatoid.
Because I had a similar patient who kind of had a fracture in the femur and the fracture of implant, both.
Yeah, and she had an infection on the opposite side.
Oh my goodness! Congratulations.
Okay, so thank you. It was a wonderful case, and as we need to start rolling along, so we go to the next part. Thanks, Vikas, again for a wonderful experience. We go on to the next part of the program, which is going to be, again, non-orthopedic. And can I invite Dr. B.D. Chatterjee to share his experience on non-orthopedic issues? He has a lot of other than orthopedics, he knows a lot of other stuff he's going to share with us. So can you start sharing, please, B.D.?
Yeah, okay. At the outset, my sincere thanks to West Bengal Arthroplasty Society for the opportunity to speak. And Rajiv actually gave me a very, very difficult task because, I would have much preferred to talk something on arthroplasty or, even non-arthroplasty orthopedics. But then he asked me to talk on, what I did to get out of the lockdown blues. And so it is something which I've never really done in my life. So
you became a gentleman. We have some common experience.
So I'm going to just speak in lighter vein, but I'm really thankful to Dr. Datta, Indrani Datta. She has made my job a lot easier, because what I'm going to say, you can take it as a sort of a follow-up on her lecture of how to sort of de-stress and be happy during the lockdown. The problem is, that just like I said, that I've not spoken on anything else other than orthopedics. And that sort of typifies our lot as orthopedic surgeons. We are, sort of single track people. Unfortunately, our science demands so much of labor, and it's so labor intensive that there's very little time to do anything else. So suddenly, when you're faced with a situation where you are not able to do your daily work, you are suddenly, completely vacant, and you don't know what to do. And then, from her lecture, I picked out a few things. This, the thing of uncertainty, that's what eats into you. And again, there are two ways of looking at it. And one is optimism. That's the other word I picked up. I think all of us need to be optimistic. Then what she said was hobbies, and I think it is absolutely, absolutely essential that we have some hobbies and we sort of indulge in them. The other thing she talked about was learning new skills. And how correct and how true she was. It is never too late to learn new things. So coming to, I think there's a disturbance coming from somewhere. Uh, Talking about myself, you see, I went back to my first love, which is painting. So that's how I tied it over the lockdown. So I'll just tell you briefly about what I did during my the lockdown. I'll share my screen. And coming back to the okay, so it is never too learn. Rabindranath Tagore started painting at the age of 60. Winston Churchill, I'm sure some of you must be aware, was a famous painter, and he started after retirement, and they all became very, 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 very good. So it's never too late to learn. So I just this is what you see now is a painting which I did as a child of 7. So I started painting very early, and in my childhood days, my paintings were picked up by the UNICEF, and then they made it into greeting cards, and they were sold for charity. And this is just one example, one of the cards which has stayed back with me. This is what I do. This is an oil painting, and I think Rajiv will also connect with it. This was the inspiration came from Pondicherry by the seaside, where I spent a great many years of my life. And this is oil painting. So I will show you some of the oil paintings, but I will not dwell on that very much on that. What I shall dwell on is a much simpler technique, which is pastel drawings, and that is something which I'll just show you how to do the pastel drawings, and I'm sure many of you can take it up. This is again inspired by my years in England. This is a typical, in Scotland, this is a typical English countryside scenery. And again, this is oil on canvas. And this is a copy of, this is a copy of a painting by Raja Ravi Verma. The original is available in the Mysore Museum. So I managed to, pinch a photograph from there, and then I made a copy of this. I believe, that there is an artist in every orthopedic surgeon, because our science itself is like making a painting. You have to have a sense of alignment, a sense of size, and a sense of proportion. It is only then that you can do a perfect internal fixation or or an arthroplasty. So it just needs a little bit of a push to get this artist out of you. And I exhort all of you to try your hand at the simple technique of pastel drawings, which I shall be showing you. This is another oil painting which I've done. Again, this is showing the play of light and shade, and if you can call it a study of still life. This is what I did in the last lockdown. This is again a oil on canvas. It shows a path in a forest with a cottage. This was my activity in the last lockdown. So coming to the main thrust of what I want to say today, how to get started on pastel drawing. So there are two kinds of pastels. These are oil pastels. So it is there, the pigment comes dissolved in oil, and this is one way to do it. But my favorite is this one. These are dry pastels. You see, they are basically pigment sticks, and you rub it on paper to get the pigment on the paper. What you see, they are called half pastels. And there's an advantage in buying a box of half pastels, because you can get more choice of colors, and the cost is also reduced a little bit. So I would then ask you this: if you want to get started, get paper, pencil, and you can get a box of these half pastels to get started. So how do you do it? You see, you see, I've I've simply applied two colors on a sheet of paper. One is blue and one is yellow. And then you work with your thumb. And as you work with your thumb, you can actually blend the colors. And you can see now how the colors have blended. So this is, you work with start with the background, the sky, then come to the foreground, and then you see, this is how you blend in the rest of the colors. Now we have got a bit of the foreground coming, and then you start working in with the details. And this is the detail. So it gives you the perspective, and it's very easy really. So all you need is, just a little bit of patience, put the colors, blend it with your thumb, and then place one color on the other. And the advantage with it's like, for instance, if you're doing watercolor, then there's a rule. You have to do the light first, then that medium, and then the depth. That's how the tones work. But in the pastel, you can go either way you want. You can do the dark first, put the light on top, or vice versa. And if you work like this, eventually, you will end up with something like this. This is a pastel drawing, a completed pastel drawing, where I've used this same technique of blending colors with my thumb. This is my work during this lockdown. I've done a study, a series of animal life, and this is just one again with the pastels. This is another one, same animal study. This is another one. And this is another one. Now here I can tell you the background is actually watercolor, because it's faster to do. You fill up the background with a watercolor wash, and then use the pastels to create the effect in front. So yeah, so that's what I have to say. And I want to share. That's all I have to say. And
can I say something?
Yes.
I think I'll have to say something.
If I assist you for a day, will you give me a painting?
I can make a painting for you. That's not a problem. Or better still, I'll make you make a painting. I'll help you make a painting.
That would be amazing. Thank you.
Wonderful.
Really amazing.
Fantastic.
Thank you. Thank you.
You're just being, I don't know, magnanimous when you say that we can all paint as orthopedic surgeons.
Yeah.
I can't draw a straight line. I can't draw a curved line. So I don't know where I'd start.
That's what you think. That's what you think. Just try, and I tell you, you try and you will discover. So what you see, the whole idea is that we don't want to make masterpieces. We're not trying to sell paintings and make money.
Those are masterpieces. Some of them are brilliant.
Yeah, but the whole idea is that to express yourself. It's a creative activity, and believe me, it gives enormous joy. You feel absolutely.
Can I propose something? Can we set aside some time once a week for you to teach us?
Yeah, sure. No. I think you showed me some wonderful paintings yourself of your better half. I think
just to share with you, he is the artist of our college. Pondicherry used to do Saraswati Puja. The idol used to come from Kolkata. By the time the idol arrived, he was missing a few fingers. Occasionally, half a face gone. PD and Kushal, he's an ophthalmologist in Amri. Both of them used to recreate the whole idol. And within 2 days, used to get a perfect idol, Saraswati idol. So I've been seeing him for...
Hey guys, hello. Yeah, look, very interesting, very nice. But by all, my wife needs my laptop.
Okay.
She's a school teacher. She has lots of work. And she irritates me all day with her work. She doesn't know how to use the laptop properly, but she needs it now. So guys, I'm having to say bye.
Next time you have to teach us cooking before you leave.
I could do that.
Yes.
Okay,
Bye.
Can we go on to... Hello?
Yeah.
Next one. Dr.
Thanks for
Indra
being-
Sharda is going to share
Thanks
his...
for being there. Thank you.
Going ahead and
Bye all.
Bye-bye, Shanja. The screen is... The stage is all yours. His passions, how he's been managing in lockdown. Dr. Shodhar.
okay, going ahead. Can you see the screen?
Yep.
Okay, how the pandemic made me discover myself. I think that's what Bidi was saying. But being a little bit older, sort of introspection is something which comes more commonly at this sort of age. So this was a time in which we had the time to look inwards and see ourselves and placing ourselves where we are, what we are doing, and etc. Getting a very philosophical, getting the time right. So discovering oneself was this. And there were so many multiple things in mind that came around during this time. And you were all thinking of so many things. And one of the things that we did improve was our skills of the computer. And with the webinars that we all had to come about and the internet communication. So we used the social media also. I think all of us got very in Facebook and Twitter and whatnot. And sometimes it became an obsession. But it was a useful thing or a useful technique to learn of communication. And it became easier as it goes by. And then the teleconsultations that were there, which I detest absolutely. But the discomforts of interaction with patients, you have to, their phone calls come, their WhatsApp images come, this and that, and you have to talk to them. And we're discovering new methods of virtual communication with them because they couldn't come. And I think we sharpened our skills of brevity. We learned to communicate in a very brief, short while. We used some abbreviations also, which again I detest. And then we knew about Twitter that has that limit, and Facebook, and you just write a couple of sentences to show what you have. And of course, WhatsApp, which we are all doing all the time. So this area which we learned our computer skills, I think, improved for every one of us. And personally, I turned to two things: music. And I don't play music, neither can I sing. I think most of us would agree with that, excepting for something like Vidi and Vikas, who can sing so well, and writing. So both together, I thought of writing about music. And what music did I know? I'm not a great classical follower. So turned back to the Bengali music, remembering the 50s and 70s. And I read and wrote about the songwriters, which we grew up with, the music directors and the singers, persons like Pulok Bandyopadhyay, Shivdas Banerjee, Nochiketa Ghosh, Sudhin Dasgupta, Gauri Prashanna Majumdar, and then Gita Dutt, Pratima Bodua, Utpala Sen, Tarun Bandyopadhyay, Shubir Sen, Talat Mahmud. This is all of the 50s and 70s, and I wrote about their lives because I could read about them. I had the opportunity to do so. And their creations and how they came into the songs, what they did to develop their skills, and how the songs were created, and their development, and then the stories behind the songs. And that was classy because there were so many stories behind them. Like Shivdas Banerjee was a revolutionary poet, and Pulok Bandyopadhyay wrote so well, but met his end, committing suicide on a boat in the river Ganges. And Nochiketa Ghosh was a doctor. And so were Gita Dutt's life, which we all know about. Very tragic. She came from Bangladesh, was in Calcutta, and then they went on to Mumbai. And in Mumbai, she was singing in a house. And while she was singing, there was a music director who was walking down below the street. He just went up. She was 14 then. They got her, convinced her father to make her sing for films, and that's how it started. But then Gita Dutt had a stormy affair, married Guru Dutt, and then Guru Dutt committed suicide, and Gita Dutt ultimately went to alcohol and died of a neurological disorder. Pratima Bodua was another person who sang folk songs from Assam. The Assamese Goal Pahari Gan, the songs. And when Pratima Bodua died, the whole of Guwahati stopped. Everybody came to a funeral procession. And that was, she was a protege of Bhupen Hazarika. And Bhupen Hazarika personally flew down to lead that funeral procession. Utpala Sen, of course, Torun Bandyopadhyay, persons whom you just perhaps may remember from your own time, but who had some indelible memories in our childhood. Shubir Sen, Talat Mahmud, etc. And all of this, what happened was that I emerged richened, as if I had dipped into a lake of really incomparable riches. I've heard all these songs before, but somehow they seem to have a different meaning and a different creation and a recollection of what our childhood was. And these were the persons over there. You wouldn't remember this person. This is Shotto Chaudhary, and he was the one. I'll just play some songs just about. I thought this would be and this is a very common song, but the first one who sang this song was this guy. And he came from a family of Jomidars, and his Jomidar house is still there in Calcutta. But there's a museum in which his exhibits are displayed. This is Pratibha Buddha, a film called Mahut Bandhure. And you could have heard this song for many times. I'll just speed it up a bit. This is Torun Bandyopadhyay. This was a song which perhaps applies still in our lives. There's an incidental story that he once, dyed his hair so that he could sing a song of youth. Shamol Mitro, the man from Noyati, who came to Calcutta and in a era dominated by Hemant Bandyopadhyay and Sutinath and Manovendra, still made his place there. A film from Baluchari, starring Anil Chattopadhyay and Savitri Chattopadhyay. The tragedy about Shamol Mitro is that he started drinking hugely. And one day while coming back from a program, he crashed his car and a head-on collision with a road. He was badly injured, almost died, then came back. And this song, of course, you know, sung by Mannade, Gauri Prashanna Mojumdar, this is Gauri Prashanna, and Nachiketa Ghosh gave the music. Nachiketa Ghosh was a doctor. He came into that. শশীকান্ত তুমি দেখছি আসরটাকে করবে মাটি তাহার বানা বাগরা বাগা পাল্টা মার Incomparable Geeta Datta. Music director was a person whom you may not remember, Rajan Shota, and the song was written by another songwriter who was famous at that time, called Anand Chattopadhyay.
একটুখানি জাস্ট একদিন তুমি শরীর ঘাম এসবেস করছিল মনটা জলের মতো হয়েছিল তুমি টেস্ট করা আমি টেস্ট রাখবেন আমরা ভ্যাকসিন
Then went to Mumbai. He became the singer of that era. He was well known for his And then, of course, there's Pluto. Pluto is still scrambling for a marry Vishnu. He's 14 years old now. He's about 98.
সবই মানে হাইপোথেটিক্যাল কথাবার্তা হ্যাঁ
And he knows at an Amerati better than me, and he loves it. And his conversation saved me from depression and tiredness. And a lot of because he could understand what I was speaking, and I understood what he was speaking. He's now obsessed with eulogy. And the eulogy is that people write eulogies after they're dead, and they don't ever get to know them. So when are you going to write a eulogy for me? And I said, when you will write a eulogy for me. So he's thinking about it. I would have introduced him today, but unfortunately only I can understand his language. He's down here below, just keeping listening to all that we are saying. And Devapi perhaps can, because inspired by him, he published 2 books, which Pluto read avidly. And the pictures. It was a good time to dig out old pictures and take some new ones. And I think Ranjana completed 8 albums of nostalgia and history. It's a great occupation, you know, you look at them back and forth and you really realize what has gone through with you, with your family members all the time. And we go over and over again that. And of course, we've all gone through Netflix, Amazon Prime, Z5, etc., everything. And nothing beats looking back at these old pictures. And writing in Bangla. I started writing in Bangla, surprising many and mostly myself. And started recording audiobooks of my stories, which are gradually coming out. There are 2 new ones on the anvil. So I write the stories and record them, sometimes on the mobile, sometimes in a better way at the studio. But anyway, it helps a lot, takes a lot of you, and it's nice. You start to think that maybe, just maybe, as BD said, most of you can be writers also. বাংলা এই কথাটা বলি যে আরে মহামারীতে বুঝলাম দুঃখ কাকে বলে। This I realized. I really didn't know that. ডাক্তাররা মৃত্যুকে মোকাবিলা করে নিজের মনকে একটা কঠিন আস্তরণে ঢেকে দেয়, কিন্তু যখন নিকটাত্মীয় চলে যায় বা কর্মসাথী হারিয়ে যায় তখন সে আস্তরণটা আর কাজ দেয় না। আঘাতগুলো দাগ কেটে যায় আর ক্রমাগত আঘাতগুলো মিলে গিয়ে একটা গহ্বর তৈরি করে আর নিজেদের ক্ষয়িষ্ণুতাকে একবার সামনে এনে দেয়। তারিখ বলে একটা সিনেমা বেরিয়েছে, দেখতে পারো। সেটা লেখা আছে যে আমার জন্মদিনের তারিখ আমাদের সকলের নথিভুক্ত, ইটস আ ফিক্সড ডেট, কিন্তু মৃত্যুদিন যে কবে আমরা কেউ জানি না। শুধু একটাই প্রার্থনা করি শেষ দিন অবধি যেন আমরা সবাই কাজ করে যেতে পারি। And now I want to show you a short film, and with this film will end what I had to say, but look at this. Well, that's it. This is the way I spent my time, and I wish I'd shared it with you. And I'm thankful to Rajiv and Vikas and everybody at WBS for giving us this opportunity. And just put on record, BD was a fantastic way to spend your time. Thank you, everybody.
Wonderful. I think just can't say anything more. So that is what a experience. Can I invite Dr. Vikas Kapoor to say a few words as a president of WBS? Vikas?
Hello.
Yep.
So there has been a lot of what can I say? This is very, very enriching experience today. What we have, it is wonderful mix of things which we have done in past and what we are doing as arthroplasty surgeons. And I think this is the way the meetings are going to evolve. I have here a lot of people, including Shornendu, who has written some wonderful Bengali poetry. I'm sure sometime he will come out with a book very soon. The way he is writing prolifically, I've read some of his work. Joydeep, he writes extremely well. There Anjan and Anando, they sing and they write equally well. So there is so much to beyond arthroplasty and beyond everything which we have heard today. I would just kind of end this whole program with a small rendition, which I wrote long time back. I think 1 year back. Many of you would have read it, but I would impose it because I think this whole situation led me to write something which was written, you won't believe, within 20 minutes in the morning at some time at 4:30 or something, So I just wrote these lines and I don't know where this inspiration came from. And these are my parting lines, which I dedicate to all my workers. मैं भी उनमें से एक हूँ. It's in Hindi. I've written a lot of Hindi work in last 1 year. I don't know where it came from which part of my soul. मैं भी उनमें से एक हूँ जो लोग सुबह उठते हैं अब तक. Till now we get up in the morning, we are sure we are still getting up after getting up. जो लोग सुबह उठते हैं अब तक नित क्रिया कर डेली कोर्स कंप्लीट करके प्रतिबिंब देख. प्रतिबिंब इज मिरर. सो जो लोग सुबह उठते हैं अब तक नित क्रिया कर प्रतिबिंब देख अपने प्रारब्ध को समझ कर नेक. प्रारब्ध इज लक. निकल पड़ते हैं नियत दिशा निर्धारित. एवरी डे वी गो ऑन द सेम ट्रैक टू द हॉस्पिटल. मैं भी उनमें से एक हूं. आई एम जस्ट वन ऑफ देम. चहूं और यद्यपि भय का वास. भय इज व्हाट वी आर गोइंग थ्रू इन लास्ट 2 years. मानव मन में वासना आभास. Even then we are running after the material things of life, although there is lot of fear, anxiety all around. करता स्वर्णिम भविष्य की आस. Maybe tomorrow will be better. We live today in aspiration of that. अपने पथ पर अडिग निरंतर. We are walking the same path as doctors. मैं भी उनमें से एक हूं. Listen to this carefully. अणु परमाणु की ये रचना. अणु is atom and परमाणु is, we know what it is. This whole world is made of cells. अणु परमाणु की ये रचना. अब उन्हीं से द्वेष और उन्हीं से बचना. We are fighting an अणु. We are fighting an atom like virus. अब उन्हीं से द्वेष और उन्हीं से बचना. The things which make us are the cells and we are fighting the cells. बनाया अब नूतन उद्देश्य. That is what we are fighting today. This is what our privilege has become. मुखौटा पहन के दिवस बिताता. The whole day we spent with a mask. मैं भी उनमें से एक हूं. मानव मुख. This is a bit philosophy. मानव मुख. The face of the man was hidden before also. छिपा तो पहले भी था. अप्रत्यक्ष था सिर्फ मुखौटा. The only thing is that the mask was not visible. We were all wearing masks in a different way. It was not visible in the society. The society always wears the mask. Nobody is really absolutely open and upfront. So मानव मुख छिपा तो पहले भी था. अब प्रत्यक्ष था सिर्फ मुखौटा, अब पहने हैं हर एक हर पल. Now everybody is wearing it all the time. थका हुआ होकर विवश निरंतर, मैं भी उनमें से एक हूँ. So thank you all of you, and I think we share the same emotion and we share the same feeling, and it is what has come out today with Dr. B.D. Chatterjee, Dr. Sardar, and all of us contributing in small ways. And next time, I think Rajiv has lined up something very interesting, which is more materialistic, I believe, in our talks. Thank you for being there, and I think we will encourage more participation next time. We will probably try to invite people from other states also to participate in such meetings. Thank you. Thanks for being there. Thank you.
Thank you, Vikas.
Everybody.
Sorry,
Thank you.
can I request Dr. Sharkar, Parthasarathi Sharkar, Secretary WBOA? Partho,
Yes, sir. Yes, sir.
some words from you before we close down.
No, sir. In this doyens of orthopedics, so I have little to say because we are actually busy with some other work. So actually, yesterday or on 5th or 6th of this month, we have organized different relief camp, and we have organized this vaccination drive yesterday, and it was a really wonderful experience. And really, this type of topic, actually, Rajiv Das ringed me and told me that this is a one topic which I'm going to organize in this Arthroplasty meeting. And I have seen the topic. So wonderful. I have nothing to say. So thank you, sir. Thank you.
No, but honestly, Kanchanda, Partho, I mean, what I would like to add is that the work that is being done by WBOA in particular during the pandemic is just amazing. The emotional support and BD and everyone is talking about the security or lack of security that a lot of us feel during the pandemic. I think WBOA has definitely managed to overcome that. সবাইকে definitely মনে হচ্ছে যে আমরা একা নই. And that is a huge bonus. I mean, you can't imagine. It's hats off to all of you. You're doing a brilliant.
একটা কথা বলি স্যার, প্রথম কথা হচ্ছে যে আমাদের স্যার আইডিয়াটা তো প্রথম কথা কোভিড নিয়ে দিয়েছিলেন আমার ডক্টর সর্দার, এবার সেটা নিয়ে হঠাৎ ওয়ান ফাইন মর্নিং আমি এটা পাই এবং সেটা আমি পোস্ট করি, তারপর সবাই দেখলাম বেশ উৎসাহ দেখাচ্ছে, কিন্তু মুশকিলটা এখানেই ছিল যে আমাদের ক্ষমতা ছিল না। মানে ধরুন আপনারা যদি সঙ্গে না আসতেন, ডক্টর বিকাশ কাপুর বলুন, ডক্টর সর্দার বলুন, আমাদের কাঞ্চন স্যার বলুন, আপনিও, আমি মানে অ্যাপোলো থেকে মানে সবাই মিলে, মানে এখন ধরুন একটা ভ্যাকসিনেশন প্রোগ্রাম চলছে, 2-3 জন অফার দিয়ে রেখেছে যে আমার ওখানে করিয়ে দিচ্ছি, কিন্তু আমরা লোক খুঁজে পাচ্ছি না। যাই হোক, সামহাউ খুব স্যাচুরেটেড হয়ে গেছে। তো এইরকম ভাবে আমরা কাজগুলো করেছি, মানে একার পক্ষে তো কোনোদিনই কেউ করতে পারতো না। পুরো কাজটাই হচ্ছে আমরা শুধু মানে মানে ব্যাপারটাকে একটুখানি বলেছি এবং সবাই মানে এক বাক্যে মেনে নিয়েছে। মানে কোনো প্রোগ্রাম কোনো জায়গায় কোথাও বলে যে কিছুতে আমি পিছিয়ে মানে কিছু পাইনি এরকম হয়নি। যাকে যাই বলেছি সে এক বাক্যে দিয়েছে, মানে একবার জিজ্ঞেসও করেনি যে কেন দেবো, কি করতে হবে বল। মানে এটা স্যার অ্যামেজিং। মানে আমি এরকম মানে এতদিন ধরে আমি দেখছি WBO, কিন্তু এইরকম অ্যাক্টিভ বললি মানে যে সবাই চাইছে যে ওই মানে একটা করতে বা করবো, মানে এটা সত্যি মানে আমাকেও একদম মানে অবাক করে দিয়েছে যে এরকম ভাবে আমার একদমই ক্ষমতা নেই। ধরুন আমি একদমই একটা মানে আপনাদের কাছে সবার কাছে নতুন সে অর্থে, সবার সহযোগিতা ছাড়া হতেও না, এবং এটা সত্যিকারে অ্যাপ্রিসিয়েবল। আমি আইওএতে আমাদের একটা ছোট গ্রুপ আছে, সেখানে আমরা পোস্ট করেছি এবং দেয়ার মানে আমাকে ভাইস প্রেসিডেন্ট মানে প্রেসিডেন্ট ইলেক্ট বা ভাইস প্রেসিডেন্ট জিজ্ঞেস করছে হাউ ডু ইউ প্রকিউর দিস ভ্যাকসিন। বললাম স্যার ইট ইজ ভেরি ইজি, ইউ ক্যান, মানে আমরা তো এইভাবে করেছি বা থ্রু আমরি, তো এটা করা যাচ্ছে এখন। মানে এখন তো দুয়ারে ভ্যাকসিন চলে আসছে আর কি, তো সেখানে তো আমরা একটা হাসপাতালে করেছি আর এত সুন্দরভাবে হয়েছে। এখনো কিছু ভ্যাকসিন রয়েছে, সেটা স্যারের সঙ্গে আলোচনা করে আমরা ওটা আরো দিয়ে দিতে পারলে ভালো হয়। আর ওটাই বলছি, ঠিক আছে।
Thank you everyone for being there. At the end, I would like to thank the Curewell. I just want to share this in 1 minute. Curewell Therapeutics, who have very kindly been a very generous sponsor. Shutanu actually pulled them in very fast within 12 hours. I just share the screen 1 minute. A little presentation from them, which I'm just put up.
একটা কথা স্যার বলবো, একটা ছোট্ট কথা, একজনের নাম না বললে হবে না। একটা ছেলে বসে আছে চুপ করে পিছনে, হ্যাঁ, ডক্টর অর্ণব কর্মকার।
অর্ণব
সাইলেন্টলি করে যাচ্ছে স্যার, মানে অদ্ভুত কাজ করে যাচ্ছে, মানে আমার দেখে ছেলেটাকে অবাক লাগে, কোনোদিন না বলিনি আজ পর্যন্ত।
একদম হাসি মুখে
দেখলেই হয়ে যায়।
একবার শুধু বলে দিতে হয় যে করে দিন বাবু।
Thank you, Arnav. Hats off to you. Thank you, WBA. I'm just going to quickly through the slides. এটা দেখাতে হয়, দেখিয়ে দিলাম। Okay, Calbona Plus is their product, so please help out. Joint Plus is the other product. They have been very gracious sponsors. PGM NT. They came up very short notice. Thanks to them, we could organize this program. And thank you everyone for being there. Please keep your diaries free on the 7th of July. Something similar I'm trying to work on, a mixture of একটু orthopedics, একটু non-orthopedics, যাতে সবাই একটু খুশি মনে বেরোতে পারি। অনেক তো পড়াশোনা করলাম, কিছু আনন্দ করা যাক। With that, good night.
Good night, sir.